There it is, man. What?
Hello, hello. Ugh, seriously? No, you plug your microphone in before you. Hello, let's see here. Hello, 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 hello.
Good morning, Terry.
Good morning. Can you hear me?
I can hear you.
Okay, making sure I turned the camera on before I tested the mic. How are you?
Good.
Good.
I'm putting you on screen.
Oh, pretty me. Yay.
Getting the pre-course slides up.
Oh. Yeah, I saw you were in there. I double checked them all to serve again. And then I downloaded the presentation to the Common Drive last night. Eek. Golly.
Good.
Wow.
Oh, I just had a quick emergent. It was an emergency, but a little panic from Teresa and Kelly on Pal's Books for next week.
Oh, Teresa. Oh, from Poison?
From residents.
Oh. I know she's back in town. I think she gets in tonight. And I told her she shouldn't work, but like the rest of us, I'm sure she's going to try and catch up on email. I totally forgot Nick's teaching today out at Hazelwood. He needed a respiratory box, and so I went out to Sim Center to get one. I went, oh, yeah, that's right. Kelly moved it all yesterday. Anywho.
Let me know when you see Dr. Hermalin on.
I sure will. God, my head's shiny.
Can you see those slides now?
I do.
Great.
Yeah, you need to start a production consulting service. Patent yourself because
I'm going to update my resume. Terry, the other one thing that I did, as we're catching up with other people on the call, in Arlo, I added dentist
As far as,
for licensure.
oh, good move. Yeah, the pre-conference. Oop. Okay, I did update that. I thought I had.
We need to work on putting music with our slides.
Then I think one of my goals, I guess there is a means of polling in Teams. I just have never tinkered with it.
Good to see some familiar names coming online this morning.
Oh yeah. Hey, Christy, I'm still waiting for Dr. Hermalin to join. I don't see her
I know, I'm kind of watching.
yet. Okay. Mm-hmm.
We've got about 4 minutes before we start, according to my clock. We're just waiting for Dr. Hermalin to join us.
We do need catchy music.
I know. Sorry you all have to listen to Terry and I chit chat back and forth. But it's a good way for you to test your audio.
And I don't see any other cameras on, so they won't be on our recording. I did.
Well, once again, I have changed the setting for our Wednesday webinars. And I now have control of who I put on the screen. So even though it says it's being recorded for those of you who are online, I did turn off your camera ability. But if we need to bring somebody online because they have a question that they would like to ask in person, you just kind of need to raise your hand, or you're most welcome to enter any questions or anything you have in the chat. So you don't have to worry about your face being on the recording.
Let me just make sure Dr. Hermalin hasn't. No, she hasn't emailed anything. Go away. Those who are on, I'm still waiting for Dr. Hermalin to get on, to get online, join the party. Get a shiny.
It's like we have a nice assortment of people this morning. Some paramedics,
Oh, there she is.
nurses.
Did you see her, Christy?
I do.
Oh, I saw her. There she is.
Good morning, everyone. How are you? I just
Wow.
heard we have a nice assortment of attendees today.
Okay, I'll give folks one more minute and we'll get the show started.
Say, Dr. Hermalin, if you want to pull up your PowerPoint and share your screen, I will let you have control.
Oh, thank you. Do that right now. How does that look to everybody?
I can see them. Oop. There they are.
Mhm.
Okay, guys, it is 10:01. Just to be respectful of everybody's time, let's get started. Again, welcome to our Pediatric Education Live Wednesday webinars presented by SSM Health Cardinal Glennon Children's Hospital. My name is Terry. I'm a pediatric outreach educator for the hospital. I want to welcome everybody who continues to support this program. We're happy to bring you pediatric education. Again, please, in the evaluation, let us know. Let us know what we can bring to you guys, and more than happy to do that. I do want to thank. I see a few names that I do recognize. Everybody who did or was able to participate our 2022 Midwest Pediatric Trauma Conference last Friday. We really appreciate you guys being there and continuing to support that program. Today's webinar will be presented by Dr. Daniela Hermalin. Dr. Hermalin received her medical degree from St. George's University in the West Indies and completed her residency and fellowship at St. Louis University Hospital School of Medicine. She is affiliated with the Department of Pathology in the Division of Anatomical Pathology with SSM Cardinal Glennon Children's Hospital and SSM Health St. Louis University Hospital, and is board certified in anatomical and clinical pathology. Guys, we are in the middle of, again, her presentation is pediatric blood management. We are in the middle of trauma season. I need to remind me of everybody of that. And I think the last number that I heard was 62 gunshots of children under the age of 17 here in the city of St. Louis. So just remember, as far as trauma resuscitation, true hemorrhagic shock, that we do need to get blood on board. So I'm going to be quiet. Without further ado, I present Dr. Daniela Hermalin. And I will monitor, just to let everybody know, mute your mics. I'll be monitoring the chat room. If you have questions, I'll address those questions. And with respect to Dr. Hermalin, I'll address those questions at the end of the presentation.
Well, thank you, Terry. I very much appreciate you inviting me to speak at your pediatric webinar sessions. And it was Josh who really invited me. Thank you so much. And I just want to say that we are now a year into the consolidation, a year into, adding some pretty amazing features into pediatric blood banking, especially in the trauma setting. And but also a year of just, reflection and, going through and auditing and looking at materials. So today I wanted to use this as an opportunity for us to think about, in general, Cardinal Glennon, and spend some time discussing something known as patient blood management, which is very rare in the pediatric setting. We have robust programs within the adult setting, but not so much in the pediatric setting. And I'm hoping to give you a little bit of a big picture of what patient blood management is and some of the opportunities that can be presented for Cardinal Glennon. So I have no disclosures at this time. Today, I hope that I can help to define elements that are important in creating a patient blood management program for hospitals in general. And then we'll specifically talk about in a pediatric setting. Then we'll describe challenges and solutions to be employed, strategies for an academic children's hospital that can improve patient blood management programs. And then finally, describe pre and intraoperative strategies to reduce blood transfusions within the pediatric setting. And I know that Terry offered to help with the chat, but I am the kind of person that really enjoys more engagement. So, I may just ask a question, and I'd love it if you guys chime in or provide your experience, because so much of what we do together is really a partnership, and knowing the process from your perspective is very important. So feel free, to kind of stop and provide your feedback on an experience. So I'm very proud to be doing this presentation today, because yesterday was World Blood Donor Day, June 14th. It was a day in which we celebrate all of our altruistic donors around the world, and also to bring awareness of the need for the importance of safe transfusion practice. Safe transfusion practice both in the collection of our blood donors and also on the hospital side. So interesting, pediatric patients use 1,800 units of blood every day. I walk into the blood bank and I see little tiny aliquots of blood made. They look like for little Barbies, a little blood unit for a tiny little doll. And that's what we have. We have these little dolls up in the NICU to, unfortunately, teenagers coming in gunshot wounds who require tons of blood products. So at our hospital, we really do see the gamut of so many different patient types. We have subspecialties, hem-onc patients, to our very specialized cardiovascular surgery patients. So we really do transfuse very much a lot of blood products at our hospital to children, and I think it's very special what we do here. In thinking about that, though, we have lots of different blood products. And I think we need to approach blood products not as something like saline, which I'm sure none of you do, but when you think about transfusing a blood product, I want you to be thinking about transfusing a mini transplant. When we think about a kidney transplant or a heart transplant, it's a solid organ. But when you're actually transfusing blood, it actually is almost like, and it is, transfusing a liquid transplant, right? So it has repercussions. It has immunologic effects, and those need to be considered. And, we need to understand that when you transfuse something, you want to be transfusing it properly with the understanding that the benefits outseed the risks of transfusing. And we have to understand that there are consequences of transfusing blood. And when I say blood, we have many different types of blood products. Of course, we have red cells, we have plasma, we have platelets, we have cryo, we have whole blood. And in those different types, we have different flavors, so to speak, so we have different blood types and even different varieties. So within plasma, we have liquid plasma, we have thawed plasma. And so many of you may have been exposed to these different types of blood products, transfusing these products. And it takes a lot of education to understand the differences and why we do it in one case, transfuse, and why another case. So today I want to just bring to your attention the importance that we need to be mindful of the blood products we transfuse and creating guidelines and practices and following these products so that we're doing it in the proper way, in the most highest way. Today, we're going to be talking about patient blood management. And I hope that this kind of plants the seed and taking this forward, these ideas. And so patient blood management, you can sum it up, and I can finish right here at this slide, is transfusing the right product in the right dose to the right patient at the right time. That's really simply what patient blood management is: the right product, the right dose, the right patient at the right time. So I'm going to just take a second to stop and allow you guys to reflect on this very simple statement, but it's very powerful. And be thinking about, in your own experience, maybe, situations where you feel like that can be improved. So again, I'm just going to take a minute for you guys to kind of let that seep in and think about maybe, there was an episode or a situation where you think, you were in a crisis or in an environment and you experienced something and there could be a way to improve that situation. And I know from my vantage point, I guess one of the reasons, my job is to put out fires. I like all the clinical stuff. I love the teaching stuff, but I think really what I get paid for is to take, challenges and put out those fires. So we have had some fires in the last year within the blood bank. And I think one of the things we really have seen recently is that the way that blood products are ordered can be done erroneously. And as a provider who orders blood products, I can see why that can happen, because the Epic order sets are very clunky. I think that they're very difficult sometimes to totally understand and do correctly, truly. And so right at the start, right, you gotta order blood products, and sometimes you order it and you mean to order it properly, but the way that the electronic system is, you may not. And so think about the down current trends that it could cause, right? If you order blood incorrectly. And it's much easier actually to order blood on the adult side because you order it in units. But in the pediatric setting, that's not the case. We order things sometimes based on weight or age. And that can make things a little bit more difficult. Another thing that's difficult is we have constant change in residents and possibly, a constant change in nursing turnover that require education too. And that makes our jobs very hard, and so I'm just giving one example that I personally have witnessed to see where that can be really optimized. So I'll just take a minute and project that back to the audience. If there are elements that you can see right away that you think can be improved. And please feel free to, introduce yourself and state what area of the hospital you work in.
We got shy folks.
That's fine. Terry, do you have any experience? Or
My name is
absolutely.
Jennifer.
Oh.
Hi.
Go, Jennifer.
This is Jennifer Williams. I'm from Carbondale Hospital in Carbondale, Illinois. And we use Epic as well. And when we're ordering our pediatric and neonatal transfusions, they haven't built the order template so that it will calculate the volume that they need to transfuse. So the weight's already automatically pulled in. The order set says 5 cc's or 10 cc's or 20 cc's per kilo, depending on their age group, and the provider chooses the amount per kilo that they want, but it doesn't automatically calculate for them. So they're still having to manually calculate the dose, which the nursing staff have been trying to get it to automatically calculate to help, because that's one potential for error there. So we're not using our technology to its full capacity, I guess. So, and we've caught some errors in that manual calculation as well. So.
Wow. Thank you so much for sharing that experience with us. And it sounds like we are aligned and we're experiencing very similar challenges. And you're absolutely right. How do we use, we have this beautiful electronic medical record that's supposed to work for us. How do we get it to work for us and improve our lives and our job? So Jennifer, thank you for sharing that. I really appreciate it.
Hey, Brody, I see your hand raised. What's your comment?
I'm sure you'll get to it, but I know there's a lot of ambulance services starting to carry pre-hospital blood that have a lot of, probably not so much pediatric protocols to give that unless ordered, but any comments on, indications of doing that pre-hospital for blood products on pediatrics?
Thanks for asking, Brody. I definitely have a passion for this area, and I'm working with some med students and residents now to offer pre-hospital transfusions. And I would say, yes, it is somewhat a part of patient blood management, and perhaps, it's novel to be really thinking about it in the pediatric setting. Usually it starts more in the adult, and we shifted to the pediatric. It wasn't something I was going to speak about exactly today, but please feel free to meet with me, after this. And if it's an area you're very passionate about, we could use all the help we can get, because we do have a project we're working on with an IRB to establish a pre-hospital transfusion program. So thank you. Were there any other insights that people are experiencing at their hospital where they can see can be optimized?
Cindy, I see your hand raised. Go ahead and ask her what's your comment.
I work in a very small rural hospital, and we have very limited blood supply. Like, we only have 3 units of O-neg on hand and no whole blood. So you may be talking about this later in your presentation, but if we had a pediatric trauma, what would be your suggestion to us how we would treat that first?
Yeah, that's a great question, and it has to do with, having a robust massive transfusion protocol for your hospital. You know, again, we are very blessed at Cardinal Glennon to offer whole blood, but you make a great point. That's because we are a large academic hospital where our blood supplier they actually produce it just specifically for our hospital, and we use it at the adult side, and we're able to kind of have a huge inventory that can be switched both in the pediatric and adult setting. We can also, again, talk specifically about that question about how to do a thorough investigation in your hospital to see the utilization that can happen if you bring in whole blood to your hospital, but it kind of takes some auditing and to look at, your program in general. Also, it's sort of like the needs of the trauma surgeons or your ED docs. Do they want it? Are they seeing that there's a need for it? And you're right, it is part of patient blood management, but a little bit of an offshoot. Okay, we'll continue on.
But Dr. Hermalin, there is a comment in the chat box from Todd Johnson. It says, other than trauma, we are slow to give blood to our critical patients, and said they see opportunity for improvement in timeliness of giving blood product.
Yeah, that's a great example. It's a patient blood management is getting that patient the product at the right time and doing sort of a root cause analysis and improving that process. So that is a great example of how we can do better within our hospital system. Thank you. So a patient blood management program needs to be hospital-wide, comprehensive, and multidisciplinary. It has to be rooted in evidence-based medicine. And we need to have measurable outcomes. And the goal is to optimize patient care, enhance safety, avoid unnecessary transfusions, and limit adverse effects. So when we have a patient blood management program, everyone needs to be invited to it from all subspecialties. So I'm speaking to you on behalf of transfusion medicine, on behalf of the blood bank. But truly, I'm not at the head of the table. It's sort of like, the round knights, the table for the knights, that we're all have an equal part in this. And, it really involves all subspecialties. And I'm sorry if I don't have yours listed. I tried to put everybody, but anesthesia, medical, including hem-onc, ED, the NICU, the PICU, and then, of course, us transfusion medicine. But as someone mentioned, IT, we need to have IT involved in our patient blood management program so that we can improve how we can order and enhance the electronic medical record and ordering. And not only that, but collecting data from our electronic medical record. We need to be able to do that in an efficient way and have someone available to us to get the information we need quickly so that we can make decisions that are data driven. Not, it feels this way, but it's like, no. See, we've got this many patients getting this many products. This is not proper. We need to make changes here. And I'm already getting a sense. We've got so many different hospitals on this call today, which I love. You got a rural hospital, that's fantastic. You have another hospital that may be more larger, community-based, and it's great to have all of your input, but truly you have your own unique issues and challenges. And so right now you should be thinking about, as I speak, your individualized challenges and quality improvement projects that can help to improve it. So someone mentioned they have maybe an issue where they only have packed red cells. We may be able to offer whole blood. That's not an issue at Cardinal Glennon. Our issue is something else. So each of us have individualized areas of improvement. It's very important, and it could be that the people on this call who are drawn to this type of lecture, this presentation, is you really need hospital champions. Now, of course, I'm a lioness when it comes to my blood in the blood bank, and I'm very much protective and want to do my best to make sure that, you know, we do have a robust patient blood management program in the hospital and things are being done appropriately. And perhaps many of you in the audience also feel very closely about this topic. To me, blood is a precious resource. And I think about the individuals who donate blood and take their time and all of the steps involved in testing the blood and getting the blood to our hospitals. We just need to treat it properly. And then on the next side, which is transfusing to the patient and not causing harm to the patient, and really transfusing in the proper way. So we need to be thinking about all of those things. So again, how do we get started? So the first thing we need to do is you do develop, you know, a patient blood management program for the hospital. And it needs to have, you know, as I mentioned, some of the main subspecialties involved and those champions at the table. And when all of you are sitting at the table, what you do is you're going to evaluate your current behavior and capture areas of improvement. So not every hospital is going to look the same. And then once you do that, you're going to establish your thresholds and develop evidence-based guidelines, which I can tell you the truth can take up to 6 months to a year to do those first two steps. You know, so that takes time. First of all, it takes time just to gather all these people. And then, you know, coming up with, you know, your evidence-based guidelines, your thresholds, and truly your metrics and how you're going to be monitoring and improving these things. So once you do that, you monitor your quality improvement projects, and then you're going to do constant blood utilization reviews and audits. And that's where, you know, having good access to Epic and pulling out that data is where it's very helpful. So the goal of any patient blood management program is that you're going to demonstrate that the quality improvement projects that you have established are successful through your interventions. So I'll give you an example. Very simply, in the old days, and even unfortunately today, physicians were trained in the adult setting, possibly in the pediatric setting, that a patient should have 2 red cell unit transfusions. And over time, they saw that that is actually harmful and that we're going to go towards a more restrictive transfusion strategy, meaning transfuse less than more. So they came up with a mantra, 1 and done. Transfuse 1 unit and stop. Check your hemoglobin again. Also, don't transfuse unless the hemoglobin is less than 7. So one thing you could do is look into seeing how many units are transfused at one time. I'm just giving you an example. And if you notice that physicians are transfusing more than 1 unit at a time and not actually checking a hemoglobin, that's an area that can be improved. And what do you do to improve that? Education and monitoring, auditing, being in touch with these physicians that are doing it in an improper way. So that's just an example. It's an older example. You know, hopefully we're seeing this trend in the past. I do oversee SLU Hospital, Cardinal, Glennon, and St. Mary's, and St. Mary's being more of a community-based hospital, I actually do see more 2-unit transfusions, I think because they haven't been educated as well as maybe academic hospitals. So that's just an example. So when you think about the tenets of patient blood management, it's really 4 pillars. It's interdisciplinary blood conservation modalities, optimizing coagulation, patient-centered decision-making, and that's where your policies come in place, medical evidence-based policies, and then managing anemia. And truthfully, the managing anemia is much more on the adult side than the children's side, but we could talk about that as well. So let's first talk about blood conservation. Blood conservation is very, I think is standard of care in a lot of pediatric hospitals. So you want to limit blood draws in neonates and children by using minimum volumes in small tubes or microcontainers, reducing blood requirements for cultures, batching lab tests, returning blood waste in lines. So those are the ways you can do it by the bedside. And I believe that all of us are really pushing to do that. Making it standardized within SSM and making it a standardized practice is really where we need to be. But also just being mindful of it, calling the lab and saying, can I add this on so I don't have to, draw another tube? And I think we are so mindful of that in the pediatric setting because we have these very tiny patients. I also want to bring to your attention on the hospital side or the blood center side, there is a unit known as a low volume red blood cell. And usually this is going to make all of you kind of cringe, but there are times when a donor donates and they don't have enough blood to fill the bag completely. So our whole blood bags are either 450 or 500 mLs. We're supposed to try to fill it up to that number. And there are times when a donor actually doesn't fill up to the entire quantity. And in those cases, they're discarded. However, it is possible to actually use them if hospitals accept them. So there are blood units that can be smaller. And the truth is they shouldn't be discarded. They're absolutely fine. In some ways, they just don't make that total bag full. And they should be used really in pediatric settings where you guys are using aliquots of blood anyways. And sometimes we don't use a full unit. We take some blood from that unit for your particular patient. So I just wanted to bring that to your attention from the hospital side and the blood center side, that there are also ways to improve blood conservation. You need to be, this is the part that's the hard part. That's going to take a year of work, which is coming up with your indications of transfusion. Neil, do you have that blood? Yeah, that card that I gave you yesterday. Yeah, thank you so much. Okay. So I'm not sure if you can see this, if I have a filter. Terry, can you see this card?
I can see it. Just pull it back just a little bit from the camera. Yep, closer to your face. It's still blurry. Oh, it kind of fades in and out as far as trying to focus.
Okay.
But
well,
I can see that. I get the gist.
You get the gist. Okay. So this is a pocket guide that I provide all the residents in the adult hospital. And on one side, it has the transfusion guidelines for platelets. And on the other side, it has the transfusion guidelines for red cells, FFP, and cryo. So every day at my hospital, this is another piece of paper you can't quite see, but you can see that there's 2 pages of a lot of data. And every day at my hospital, I review every blood transfusion that was given to our adult and pediatric patients. And I focus on platelets. And I have the residents who are behind me joining this call. And together we review inappropriate platelet transfusions. And what I have found is that we have very robust policy in the adult hospital of when a platelet should be transfused. We have very good indications. but we do not have those guidelines for the pediatric hospital. And I have found that it's a little bit in the Wild West. So children are being transfused platelets in different scenarios at different platelet thresholds. And that's one area I think can be incredibly improved, at least at Cardinal Glennon. And perhaps I'm preaching to the choir to all of these hospitals. I think it can be an area of improvement. Now, number one, I just want to say, and unfortunately, you know, I don't like to consider money all the time. Sorry, one second. But platelets are our most expensive product. So platelets cost about $500 a unit. Platelets have the highest risk of septic transfusion reactions because they are stored at room temperature. And, you know, platelets are also a precious commodity. We have to think very closely how we transfuse them. So that to me is an area of improvement. And again, we want to be thinking about all subspecialties. The threshold for a hematology patient, oncology patient, can be very different from a threshold for a patient who is, you know, in cardiovascular surgery. So we need all of these subspecialties at the table to talk about what the medical evidence-based guidelines should be for each subspecialty. So when I review the transfusions of each day and I see that little baby Rose got transfused and I look up her history and she had a platelet count of 50, you know, but she was getting, you know, maybe she was going for some type of, you know, a procedure, then she meets the guidelines if we all agree to that. So that's an area that I think can be largely improved. So again, I'd like to take the time as a reflection point to ask any of you, are you aware at your hospital that you have very good policies on transfusion guidelines for all of your products? And are they based on different subspecialties? I want to, again, reiterate the importance of thinking through a restrictive blood transfusion strategy. And, you know, I could come back to talk to you specifically about platelets. It is showing that, you know, having a liberal transfusion strategy for platelets, especially in neonates, is actually better than, you know, giving platelets. That actually improves outcomes in the neonatal setting. So anybody with some feedback on your particular hospital and your policies or guidelines?
Dr. Hermalin, there is a comment that they don't know, but they're going to ask.
Okay, that's
they're
all
going to find it. They're going to find out.
That's wonderful. Thank you. Yeah, that's good. And this is exactly what this is supposed to do. Get you thinking. You know, what are we currently doing and what are our guidelines? Which, unfortunately, in the pediatric setting, and guys, you're not alone. It's very scarce. So this is an area, you know, we could really improve on. So now I'm going to switch gears, speak specifically about surgery and how we can use interventions and strategies to decrease the use of transfusions in the pre, intra, and post-operative surgical setting. And the preoperative strategies, in the adult setting, we really think about improving and augmenting hemoglobin, really in the background of iron deficiency anemia. I don't know much about that in the pediatric setting. And if we really see anemia in children, definitely in young women who are in childbearing years, you know, we could be missing anemia in those types of children. But what I have seen as one of the biggest challenges in the preoperative setting, from my perspective, is in general, pre-admission testing is sort of negligible. And that's, I understand, because, you know, at our hospital, we have children who are coming from outside the state, driving very far to get to our hospital. So they're not coming in a day before and doing pre-admission testing. They're coming the day of. And in fact, they're actually starting the surgery, putting the IV in, and then drawing labs. That's what I see a lot of. Now, is that the best way? I don't know. I don't know if there's any other way. It's a different culture in the pediatric hospital. But I just wanted to bring to your attention that that could be an area of improvement, and it does affect patient blood management, thinking about the, pre-admission, pre-operative testing. Anybody with feedback on that or have a different process at your hospital? Please feel free to put it in the chat. Okay. Well, intraoperative, there's actually different modalities that can be used. We have something known as acute normovolemic hemodilution. I'm not going to speak too much about that today, but what it is that you actually can draw blood off the patient prior to the surgery and then give it back during surgery to prevent the need to transfuse additional blood to the patient. And that has to be used in a patient that actually is stable and has a somewhat stable hemoglobin and hematocrit. Cell salvage is a machine that is present during the procedure in which you actually take the patient's blood that's coming out of the body during surgery and returning it back. It goes through a filter, it's cleansed. You can't do it in an unsterile field, but again, it's a way to mitigate the need to transfuse other blood products. The use of antifibrinolytic agents, especially in trauma setting, or factor concentrates, is another way to decrease the need to transfuse blood products. Shortening the length of cardiopulmonary bypass circuits or adding red cells to the the CPB circuit is also another way to limit the amount of transfusions that you would have to use. So these are intraoperative strategies that you might want to think about. Are there any that I'm missing that maybe others in the audience are doing? I want to bring to your attention something that is really amazing. We do have a few Jehovah's Witness patients, and in the St. Louis area that we take care of. And I always find it amazing that when we have these types of patients who, for religious reasons, do not accept blood products, our surgeons really do their best to kind of tie down those bleeds really strongly because they know they're not going to be able to transfuse blood products. So if we can approach surgeries as if everyone's a Jehovah's Witness patient, I think that would be really fascinating. Do we have any comments in the chat, Terry?
No comments in the chat, but kind of to that thought, and here I go again. Just again, for our community hospitals and for our EMS guys, to stop the bleeding. Put tourniquets on, pack those dressings, direct pressure, et cetera, and then hopefully we don't get to the point where they don't need blood products. Just a thought. See what I got a hand raised.
Okay.
Yeah, this is Brody again. The TXA, as long as I have found that to be amazing, that it's being used in pediatrics as well. I know there's a lot of research with calcium helping as well. So with bleeding of TXA and calcium for adults, you almost don't even need blood products if those are pushed fast enough. Is that the same for pediatrics as far as calcium goes with blood loss?
You're teaching me something new. I didn't realize they're adding calcium to the regimen. So it's something I would have to look into. So thanks for sharing that with us.
That came from Dr. Jeff Ziegler, where it's activating platelets, or it's the trauma patients are kind of hypocalcemic. So I'm not sure if it's kind of a national thing or if it's mostly kind of what they've seen at WashU. I'm not sure.
Okay. Well, when we give blood products, it has anticoagulant in it. So when we transfuse rapidly, especially in the trauma setting, we have to be concerned about citrate toxicity. And so, and that might be the reason why they're, infusing calcium, is to avoid citrate toxicity. Children can be maybe more sensitive to it as well. They're smaller. Usually in our Cardinal Glennon hospital, because I've looked at this, the patients that have massive transfusion protocols that get tons of blood products happen to be adult weight. But again, adults can experience citrate toxicity. You're right, calcium is a cofactor in the coagulation system. So it is important and it can aid in stopping the bleed. But I was not aware of it being used in lieu of TXA. But I'm wondering if it maybe is being used to combat citrate toxicity. But I will look into it, Brody.
Dr. Hermalin, there's a question. In the old days, we had the capability to do auto transfusion with chest tubes. Never seen it used. Is that still a practice? Is that still being done that you're aware of?
I have never seen that or have heard of it. But auto transfusions through the chest tube.
With chest tube, yeah. I'm assuming with the bleeding or chest tube drainage.
I'm not. Is anybody else on the call familiar with that?
Let's see. Ooh, here they
Maybe
flow.
Brody.
Yeah. Again, there's a question about transfusing. Any idea how fast to infuse calciums in massive transfusion protocol situations? Again, somebody was taught this as a new nurse. I also have never seen it. Again, someone says they've seen the same, that it's being done. Yeah, it's stuff. Again, this is stuff that's coming off the back of the chest tube or the pleurovac, which is the drainage container, which they use then to auto transfuse back into a patient.
Wow. Yeah. I mean,
Yeah.
that sounds like a great conservation strategy. That's something I would probably have to ask Josh Dougal about, or one of the trauma surgeons,
Surgeons.
Dr.
Yep.
Thompson.
Yep.
Maybe, Terry, we could keep a list of these great questions and try to get them answered and return them back. I want to finally just touch upon the use of viscoelastic testing in pediatric patient blood management. This is the use of it's a type of coagulation test. And perhaps some of you have heard of this, but it is available at our hospital at Cardinal Glennon. And what I'm showing you, because now you might be at a point in time, let's see, it's 9:45. Maybe some of you could use a glass of wine or a little shot right now. We can relax, or margarita. But right here, what you see is this is kind of a cute schematic that we have what's called tracings, these viscoelastic tracings. And they kind of resemble different types of alcoholic beverage glass shapes. So I'm going to explain a little bit to you what this is, but this is the background is that viscoelastic testing, and in our hospital, we call that TEG, thromboelastography, is a way in which we can measure a patient's ability to form a clot, a patient's ability to form a clot, to keep that clot, and break down that clot. So right now, I'm going to ask anybody in the audience can tell me, what are the classic ways we test a patient's coagulation system? What are the traditional or conventional ways that we test patients' ability to form a clot? Terry, is there any answers in the chat?
PT-PTT.
Beautiful. Exactly. We use the PT-PTT, which many of you may know is a plasma-based test. It's looking at just the coagulation factors. We could also do a CBC and see how much platelets a patient has. I'm going to stretch your brain a little bit and return you back to your basic sciences. And when a patient forms a clot, it needs two things. It needs platelets and it needs fibrinogen. Okay, so when a patient has endothelial injury, unfortunately, we have a scrape, the first thing that happens is platelets stick to the area where there's endothelial injury. Thrombin gets activated, and the coagulation system then starts. There's a burst, and we go from 12 to 11 to 9 to 8 to 10 to 2 to 5 to 1. Boom, we go from thrombin to forming a fibrin clot, and we have a platelet plug, and now we have a fibrin clot. And all of those things happen so quickly, so quickly. Traditional lab testing is only looking to see if your factors are working. Viscoelastic testing is taking a patient's whole blood and looking to see if the whole system is working. Okay, so now I'm gonna show you, this is in our lab. These little machines are known as a TEG Success. They were designed to be as a point of care test. And some hospitals actually may have them at the patient bedside or the OR or the trauma bays. We currently have them in the lab, but basically this is a analyzer, very, very simple to use, that shows a patient's entire ability to form a clot. Okay, we have 3 cartridges, and I'm not going to go too much into them, but this is what I wanted to show you. Kind of hard to see, but it provides you with a trace, and it gives you a lot of information. It gives you what's called an R time, an MA, and a LY30. Ooh, sorry. And what this does is it tells you how quickly a clot can form, how stable is that clot, and how quickly does that clot break down. So you can imagine if you have a trauma patient, you want a trauma patient to have coagulation factors. You want that trauma patient to form a clot and make sure that clot sticks. And you don't want that clot to be broken down too quickly. Okay, I know that's a lot of information at once, but that's the information we can get from a TEG study. So much more than just, a PT-PTT. And from here, we're able to then personalize transfusion practice. So here we're able to get a lot of information to say, this person needs plasma, this person needs fibrinogen, this person needs platelets, this person may need TXA, all from a TEG study, which I think is just amazing. So at Cardinal Glennon, we do offer TEG for the pediatric patients. And truly, it's not just used in the trauma setting. It can be used in other settings. In the adult side, it's used in CT surgery. It's used in the ICU. It's even can be used to help understand COVID coagulopathies. Thank God we don't see those as much. But I just wanted you to keep in mind, this is a way that we could be monitoring patients' ability to form a clot and personalized transfusion practice. So when you hear about TEG, or you hear about, in general, viscoelastic testing, this is what they're talking about, and it's a huge pillar of patient blood management. Okay, so I'm going to finish there. And I was just going to show you, this is what the tracings look like. And I love these tracings because we offer our physicians and anyone who really would like to have access to the live tracings. So you have a patient come into the trauma bay, we start measuring, and then you can watch on the computer this tracing form. And that gives a lot of information very quickly. There are a ton of translational research opportunities happening at Cardinal Glennon. We have a pediatric surgery resident actually doing a study on traumatic brain injury in trauma and the use of TEG and being able to phenotype these patients and deliver blood products to them. So a lot of different projects going on with TEG and trauma and perhaps even other areas. I have a resident who's interested in looking at how can we use TEG to help understand patients, little babies that may be developing necrotizing enterocolitis. Is there a way that we can kind of catch that early on by the use of TEG? So to finish, we do, all of us have a shared goal. We want to, provide individualized goal-directed therapy, reduce inappropriate transfusions, stratify our patients, improve patient outcomes, and reduce cost and wastage. That's really, all of us want to do that together. So to me, the best resource, if you guys really are interested in learning more about this and bringing this back to your hospital leaders, that we do have an organization in the United States known as SABM, the Society for the Advancement of Patient Blood Management. They have gorgeous resources, so you should go online and check them out. I'm also very loyal to the AABB, and they also too have a great patient blood management program. So please check out either one of them. I do recommend the SABM. They have free PDFs, just really beautiful materials that can help you get started. With bitter sadness, I do want to say that I'm actually moving, and I'm going to be working at the blood center starting July 1st. So our blood center is Impact Life, and I will no longer be the medical director for St. Louis University Hospital and Cardinal Glennon, but I'm actually going to be moving to the blood center side, and I'll be the chief medical officer for Impact Life. So it's a big move for me, and I will very, very, very much miss my job here and my role here. I just love working with all of you, but this is a very special opportunity that I couldn't resist. But I'm super active on Twitter. That's me on Twitter, at Hermalin MD. I like to teach on Twitter. I'm also going to be staying on as an adjunct professor, so I'll be teaching at the university. And please, I'm happy to come back and teach other areas of transfusion medicine, specifically trauma resuscitation, or we could talk about the use of platelets in the neonatal setting, whatever you want. It's what I love most, is teaching blood banking topics. So with that, I'll leave you guys for additional questions, and thank you again for inviting me.
Dr. Hermalin, oh my gosh, can't appreciate your passion for this. And it takes a village, like you had said. And you had talked about data collection and stuff like that. There was a question early on from Highland: are there specific items or reports that are in Epic that would be of most benefit for reviewing and auditing? And are these reports, or are you aware that these reports would be available cross-institutional if you had a different hospital that was using Epic?
So the question is, again, just accessing data and doing the best.
Essentially Epic reports.
Mm-hmm. So I do also, I feel very challenged by this. There is supposed to be someone for our ministries that provides this information. And I have found in the last year it difficult to truly track down that person. Maybe it's turnover, but it's something we need to be doing better. So I'm embarrassed to tell you that the answer is I don't know. But there is how would you say it? There is a group, a committee at the regional level that should be working on these items, and I will bring it all the way to the top. And it's something, Terry, that we should be getting back to everybody about.
Oh my gosh, I'm trying to keep track with all these questions. I'm saving all these. No,
you know what, Terry, there may be a way that we could synthesize, get the text questions after the
Absolutely. That, and we are recording. 2 questions.
Okay.
How long does someone who received donor blood have DNA of somebody else's before it leaves?
The donor DNA that's in plasma or red cells.
It doesn't say.
I don't know how long it really is. How long it takes to I don't know. I don't know. Yeah,
especially in massive transfusion. I've got a comment from the Epic question guy. Said, we are a critical access hospital and our pediatric population is usually limited to ED visits. In the case of pediatric trauma and questions related to the use of blood and blood products, are we able to call an access line to get advice about what and how to provide to the patients while, again, awaiting transfer? I mean,
Wow, that is an amazing idea.
we have the access line, the access center line. That's a place to start. And most, again, you guys don't have that number. Again, I can certainly send that number out again. Why are TEGs not used more frequently in ER settings for non-traumatic transfusion needs?
Can you give me an example of when you would want to use them? Remember that TEG is used to help personalize transfusion practice. So really, if I had my wish, I would make it so that we have remote refrigerators in our trauma bay. So really, the patients who should be getting TEG studies are the ones that really you're taking out blood products for, because you want to establish their baseline. So we have a protocol that you're going to establish their baseline of what their coagulation status is, transfuse them, get them to the OR, and then post OR, you're going to measure again. So really, patients that do not really require blood products don't need TEG. And we did a very quick study for a month that looked at TEG for all level 1 and level 2. And boy, did we waste money. Patients who have level 2 traumas, they do not need a TEG because they don't get transfused. But I would love for if I didn't clarify that answer, I would love to understand more what the rationale was.
I've got a hand raised. I'm from
Okay.
Elizabeth Wright. If you're still on. Elizabeth, are you still there?
Yes, sorry, I was in a patient room.
That's okay. Oh my.
I'm trying to listen. What was the two resources for the American Blood Bank, and what was the other one?
You know what? I will send them. But the first one was SABM,
Okay.
and that's
SABM.
the American Society for Patient Blood Advancement. And
Okay.
the second one is ABB. And again, I will send those resources to you guys because they are great to have.
Another question, Dr.
And the other
Hermalin.
thing, the packet that you give to your residents. The packet you give to your residents, is that some information we could look at as well?
Yes, so I can send you an example of what I'm holding up right now. It's a pocket guide. And yes, I would love to share it with you. Again, this is not for peds. This is adults. And I want peds to have one as well.
I got another question.
All right, thank you very much. It was a great lecture.
Sorry, Elizabeth.
Thanks
How long
for
does it take?
attending.
How long does it take to get a TEG results?
It takes up to 40 minutes to finalize the results. But again, it's a live tracing, so you can watch it as it is being analyzed. So, the truth is there's a time you collect it from the patient, it gets tubed to the lab. There's that little time in between. If you had it point of care at the patient bedside, it's seconds. But from start to finish, it takes 35 to 40 minutes.
In a perfect world, Dr. Hermalin, and just for my own education, it's just the use we've begun to use again whole blood for MTP versus components. And in a perfect world, I'd love to hear more about that.
Yeah. So a year ago when we consolidated, the first what we call the trauma pack, which is the first blood you receive, is whole blood.
Right. I mean, again, in a perfect world, as far as data collection, and you talked about that it takes a village champions to do this. Again, for mainly for our EMS colleagues that are still on or that are on, and then for like our small community hospitals, how many tourniquets you put on to stop massive bleeding so that these people don't need blood when they get to the trauma centers. If that's data that would be helpful in what you do, again, that's just a place where again those folks can start. That's a question I've got is how many tourniquets do you actually have to apply, and does again so that people don't bleed out. Man, guys, most questions I've ever had for any lecture.
I take that as a compliment.
I really appreciate it. I'm like trying to keep up. Anyway, it's recorded, so I've got all the questions. And then who asked them, we can look certainly at the rosters and get answers back to you guys. Again, I totally appreciate everyone's participations, all the questions.
Elizabeth has her hand raised. Elizabeth, if you want to go ahead and unmute and ask your question.
I think she was the one that
I
asked.
actually just
Yeah,
didn't
yeah, I
unraise
think-
it 'cause I was
Yeah,
waiting for
okay.
the patients.
Yep. Again, Patrick. Let me get to that last comment. So we do have access numbers, but again, we do have access numbers, but was wondering if they're able to communicate while waiting transport team to get here. I believe it would take about an hour for our team to get there by ground, allowing us to be able to start proper and safe treatment as soon as possible. Again, great comment, Patrick. Any other questions? Any other comments? Again, appreciate your time. Thanks for continuing to support our program. The QR code for the survey is up. We'll give you a week to complete it, and I'll get CEU certificates. Our next presentation next month was a request for Child Life. Child Life, we have the luxury of having Child Life in our hospitals. Again, but Child Life, Child Life for our community EDs, for our EMS providers, just hopefully tips of what we can do. Again, help those kiddos. Hope we can treat those kiddos better. Again, any other comments?
Yeah, go donate.
And everybody donate.
That's my little plug-in. Yeah. As you mentioned, we're in trauma season, and every donation I very much appreciate. Thank you.
And Dr. Hermalin, thanks for an amazing, amazing talk.
Terry, thank you for inviting me. And like I said, I would love to come back. So please keep that in mind.
Good luck in all you do.
Thank you so much.
You're so welcome.
Take care.
Okay, guys, we'll leave the slides up just so that everyone can get the evaluation. We'll leave those up for a little bit longer. Again, not to beat a dead horse, but thanks for continuing to support this program. Hey, Christy.
Yes, sir.
Hey, I did in the chat. Oh my gosh, I was trying to keep up with all the chats and all the questions. Oop, I make sure somebody else didn't. I did find a button in the chat rooms next to each question that did say save this message. So I tried to tag all those with all those questions, but I don't know where it goes to. But then again, we did record.
And I do believe it's part of the recording. I have an attendance record and a record of the chat.
Oh, you are.
That's
amazing.
a Teams feature, so I think
You're
we're
amazing.
good.
Absolutely perfect. There was a comment. Yeah. And so, again, thank you. These are great classes, and I love the ability to access them by Teams. So, and again, let me get this. There's somebody else wants the slides. For mercy.
We will, all of the handouts and stuff that we get from Dr. Hermalin will attach to an email that we'll send out to everybody who completes the survey.
Okay.
I think that'll be the best way to get that all out.
Okay.
And thanks for all the great comments and questions and everything.
Oh
this
my
was
gosh.
an awesome presentation.
Oh my gosh. I'm like over the moon. She's obviously extremely passionate about what she does. But yeah, I was trying to talked about data and the EMS guy again. Again, the ultimate goal was for all those ambulance guys to carry whole blood versus component blood, and I wish I had had time for her to discuss that, because I see that being certainly after, not in my tenure, but ultimately the ultimate goal is those ambulance guys carry whole blood. She kind of discussed that, but I'm like, guys, count the number of tourniquets you put on, keep track those. That's data. She had talked about that, but yeah, I tried to. And I think, yeah, he addressed the questions I was getting prepared to ask. I think there's only me and you. Yeah, there's like 4 other people still on.
I'm gonna give them probably till 11:08, and then I'm going to close the meeting.
Okay. Oh my gosh. Yeah, if those guys had to transfuse. I'll just call him. I was trying to keep up on, so I pulled up the roster and just tried to find out where people were calling from. What organizations. Two, three. Wait a minute. There was. Okay. And now there's a trauma.
Okay, I'm gonna end it so we can go check on that.
Okay. Thanks, Christy.
Thank you.